Three, two, one. Welcome back to this lecture on the basics of receptor pharmacology. This particular module focusing on serotonin, perhaps one of the most well-known neurotransmitters in psychiatry, also referred to as 5-hydroxytryptophan, abbreviated 5-HT. We're going to talk about the functions of serotonin in the body and understand the different types of receptors for serotonin and how they are used by different drug targets. And this is one of the more complicated systems, at least in terms of the number of types there are. As you notice, there are 14 different types of serotonin receptors. Happily for you, I'm not going to go through them in excruciating detail, but I do want to give you a little bit of an overview. Now, of course, we associate serotonin with psychiatry because it has significant effects on mood and anxiety, but it also has an impact on appetite, on sexual function, on sleep. And outside of the brain, it has an effect on platelet aggregation, so that we know that there are serotonin receptors on platelets, for example, which can contribute to easy bruising for people who are on serotonin reuptake inhibitors, but also things like sweating and yawning, and to some extent effect on blood pressure. This particular neurotransmitter originates, again, at the top of the brainstem in an area called the Rafe nuclei. And it is created from tryptophan. So there again is a hint in that 5-hydroxytryptophan. And because it's a monoamine, it is broken down by monoamine oxidase. And as I mentioned, there are a lot of receptors, so we'll get to that in a moment, for serotonin in the body. As you can see here, here's the breakdown. So we start with tryptophan on the left, becomes 5-hydroxytryptophan, serotonin, and then finally actually breaks down into melatonin. So this is again one of these situations where we get kind of 2 for 1 out of the same, we get 2 neurotransmitters out of the same beginnings in an amino acid, in this case tryptophan, which is found in things like milk. So there's different ways that we can act on this presynaptic serotonergic neurotransmission. So these are presynaptic agents, and we can either inhibit the degradation of the serotonin, as we do with MAOIs. We can cause it to be released, as we do with amphetamine, and particularly with methamphetamine, or MDMA, causes a significant release of serotonin from the presynaptic vesicles. And then finally, the conventional antidepressants that you're familiar with, such as escitalopram, cause the reuptake to be inhibited, as we talked about in an earlier lecture. So let's take a look at these receptors, because wow, there's a lot of them. So there's 7 main families of serotonin receptors, and then we have these subfamilies. So within serotonin receptor type 1, we have 3 subtypes, again, 3 subtypes at the 2 receptor. And so it accounts for actually 14 different receptors, which means that we have a very potentially target-rich environment for pharmacology. So let's take a look at some of the agonists, and remembering that agonism means to activate either wholly or partially the receptor. So these are serotonin receptor ligands, or that activate the receptor. So with the serotonin 1A, we have things such as buspirone or buspar. Interestingly, it looks like cannabidiol, or CBD, is a serotonin 1A receptor agonist, and also vortioxetine, or Trintellix, has some effect on this. The triptans that we use to treat migraine headaches work on the serotonin 1B and 1D receptor as agonists. And classical psychedelics, such as psilocybin and LSD, require activation of the serotonin 2A receptor in order to have their effect. Now let's turn our attention to the antagonists. So what happens when we block these receptors? So the main receptors we might block would be serotonin 2B and serotonin 3, and also serotonin 2A. So the atypical antipsychotics often will have at least partial antagonism of the serotonin 2A receptor. And as you'll find out when we talk about antipsychotics, that actually causes a release of dopamine in areas of the brain which we want to have more dopamine activity to improve cognition. If you've ever given a patient trazodone or mirtazapine, you've also given a serotonin 2A antagonist. So in this particular case, it also seems to have this antidepressant effect, as as we can sometimes see from atypical antipsychotic augmentation as well. And then finally, if you've ever given a patient Zofran or ondansetron, you've given a serotonin 3 antagonist. So that helps with nausea and vomiting. So these are the molecules, the medications that block the serotonin receptors. So as I mentioned, the most relevant drugs in psychiatry would be the serotonergic antidepressants. So these are things like SSRIs that block that reuptake of serotonin back up into the presynaptic neurons. So it hangs out in the synapse a bit longer, more likely to make it to the receptor and have its effect. But also we block specifically the serotonin 2A receptors with atypical antipsychotics to help increase dopamine release in key parts of the brain. As I mentioned, psychedelic drugs can have either a directly serotonin releasing effect, as they do with MDMA, or can be agonists on the serotonin 2A receptor, as is the case with psilocybin and LSD. So serotonin is a ubiquitous drug, not a ubiquitous drug, a ubiquitous neurotransmitter in the body, but it has a lot of effects outside of the central nervous system as well. So as I mentioned in an earlier talk, serotonin receptors in the gut, for example, have a significant influence over transit time. And so when we increase serotonin activity there, we tend to increase transit time, and that can account for some of the diarrhea that we see in SSRI treated patients. But this ubiquity of serotonin and also the many different subtypes gives us a very enticingly target-rich environment for psychopharmacology, and this is undoubtedly going to be a system that will be of interest for many, many years to come. So thank you.